Today's topic is Otitis Media. Let's learn. The anatomy of the ear. The ear is divided into three parts. That is the outer ear, the middle ear, and the inner ear. So the inflammation of the middle ear or the infection of the middle ear, that is what we call otitis media. And from the name, otitis meaning inflammation of the ear and media meaning the middle ear. So otitis media, this is the inflammation or infection of the middle ear. Otitis media is divided or classified into two. That is acute otitis media, and this is when we have acute inflammation of the middle ear and the mastoid ear for less than 2 weeks. Whereas chronic otitis media, this is a chronic inflammation of the middle ear and the mastoid cavity for greater than 2 weeks. Or when this infection, that is acute otitis media, extends more than 3 months, then we classify that as chronic otitis media. So epidemiology, it is peak in the first 2 years of life, and the reason behind that is because of low immunity and also breastfeeding in supine position. But more so importantly is because the gestation tube of a child is usually short, more horizontal and patulous. So 50% of the children in 1 year of age will have at least one episode of otitis media. A third of the children will have three or more infection by the age of 3 years, and 90% of the children will have at least one infection by the age of 6 years. So the risk factors of acute otitis media include craniofacial abnormalities such as cleft palate, Down syndrome, passive smoking, this is in adults, low social economical status, overcrowding, and formation. So the etiology of otitis media, we grouped otitis media as acute and chronic. So that's the same way you're going to categorize in terms of etiology. So acute otitis media is caused by group A streptococcus, Haemophilus influenza non-type table, Moxarella catarrharis. So these are the most common, and the first two you have to know. Whereas others, you can have Staph aureus, you can have Pseudomonas aeruginosa, you can also have respiratory syncytial virus, which is also associated with otitis media. So in terms of chronic otitis media, the first two you have to know, and this is Pseudomonas aeruginosa and Staph aureus. In addition to that, you can also have Proteus and Klebsiella. So the things to take away from this slide is acute otitis media is caused by group A streptococcal and Haemophilus non-typeable influenza, whereas chronic otitis media is caused by Pseudomonas aeruginosa and Staph aureus. So the pathogenesis of acute otitis media, and the first one, it usually starts by an upper respiratory tract infection. So the patient will come in with an history of upper respiratory tract infection, and then afterwards will lead to the blockage of eustachian tube, and then after blockage of eustachian tube, this will cause accumulation, and because remember this is an infection, accumulation of fluid in the middle ear and ascension of bacteria through the eustachian tube. So afterwards, this is what we are meaning by the accumulation of fluid. As you can see, posterior to this or behind this eustachian tube is accumulation of fluid behind it. In addition to that, you will have the suppuration of this fluid in the middle ear. Suppuration means it becomes just pus, and then later you can have dissolution of that fluid or dissolution of that infection or inflammation that can lead to complication. And one of the complication is you can have perforation because this is kind of distant. You are pushing the ear, you are pushing the eardrum into the external ear. So that pushing, it will number one cause pain. That pushing can result to a complication, that is the perforation of the eardrum, and when it perforates, then this is now when you're going to have evidence of otorrhea, that is fluid discharge from the outer ear. So this is what we mean, number one. So this is an eardrum that has perforated, and you can see the suppression of the fluid and the discharge. So the stages of acute otitis media, if you have understood the physiology of acute otitis media, then this will be very easy for you. So the first one is the stage of tubal occlusion, and this we have edema in the perima of the nasal end of the eustachian tube, and this will cause reduced hearing and less marked otorrhea. And then the next we are going to have pre-suppuration stage, and this is when you have inflammatory exudate into the middle here, and you will have marked ear pain and high fevers, and the child will be very reckless. And the reason behind this, because we have already inflammation and exudate, that is fluid in the middle here, this will push this eardrum. Like for example, you can see the bulging of the eardrum. That pushing of the or bulging of the eardrum usually causes a lot of pain. The high fevers will be caused by the infection, and the child being reckless will be caused by that pain. So we go to the suppuration the stage of spiration, and this is the pus accumulation in the middle here. And as we have said, we are going to have excruciating ear pain and high fevers. And later now we will go to resolution or complication. So that inflammation or infection can resolve, and just it resolving and nothing will happen, or it can go to complication. And in terms of complication, you're going to have perforation of the eardrum. And when it perforates, what is going to come out? That fluid or that pus is going to come out. So in terms of in clinical presentation, you're going to have otorrhea. So tympanic perforation. So when it perforates and the pain was being caused by this purging or the pushing of the tympanic membrane, then the pain is going to subside. So the perforation of tympanic membrane, pain subside, and you're going to have pus discharge. If you understood the pathophysiology, then this will be a very easy thing for you. So the clinical presentation, we have otorrhea for those above 2 years, and this otorrhea, as just mentioned, it will result with perforation. In addition to that, we also have increased irritability or recklessness, and fever will have spiked, and vomit. The patient may vomit, and the patient, as we said, will come in with a history of upper respiratory tract infection may be present. So the examination finding, so when you do examination finding on this child, will have fever, and this child will be very irritable. You're also going to have red tympanic membrane, as you can observe here. You can also have bulging tympanic membrane with pulse, which you've already observed. And now after it has perforated, and when you're going to complication, you're going to have pus draining from the ear and perforated tympanic membrane, as you have observed. So the investigation, acute otitis media, this is usually a clinical diagnosis. So it's usually clinical diagnosis is there is no need of investigation unless one has other systemic symptoms. So the treatment of acute otitis media, we are going to begin with supportive treatment. In supportive treatment, you give antipyretics because you say this patient will come in with fever and pain. So you give antipyretics, and also you control the pain using analgesics. Definitive treatment, because we say this is mostly caused by bacteria, and which two bacteria did we say are for acute? Group A, streptococcal, and non-typable Haemophilus influenza. So the drug of choice is usually penicillin, and usually we prefer high doses to be used in due to streptococcal resistance. In addition to that, the dose is usually 90 mg per kg per day, which is usually divided into 2 doses. So the duration of treatment is usually 10 to 14 days. In addition to that, you can use trimethoprim sulfamethoxazole, or you can use cephalosporins. So you can also do tympanocentesis, just as you tympanocentesis is the removal of fluid into the middle ear. From the middle ear can be done if the pus is under high tension. So the sequelae of acute otitis media, this is just we have mentioned. You can have resolution or you can have complication. And complication could include perforation of the tympanic membrane, otitis media with effusion, formation of cholesteatoma, which I am going to make a video on about that, hearing loss, or progression to chronic otitis media. So this is perforation of tympanic membrane, and this is otitis media with effusion. So risk factors to complication. So who are more predisposed to having risk factors? And the first one is young age or older patients, poor social economical status, virulence of organism, immunocompromised host, and then craniofacial abnormalities, as we said, cleft palate, and under treatment of otitis media. So the complication will divide them into intratemporal, intracranial, and extratemporal. So in intracranial, you can have mastoiditis, that is the infection of the mastoid, and this will result to the swelling of the mastoid. You can also have petrotitis, and this will result to diplopia. And then you can also have facial paralysis. This is when you affect facial, and you can see this patient as presented with facial paralysis. You can also have labyrinthitis that will have dizziness, and labyrinthitis is an infection of the inner ear or the rampids in the inner ear. So intracranial, mostly this will be abscesses, and you can have extradural abscesses, subdural abscesses, brain abscesses, meningitis, that is the inflammation of the meninges, lateral sinus thromboblitis, and otitis hydrocephalus. So as you can see, these are images, is a CT scan showing us about an abscess. In addition to that, this is an brain abscess, this is an subdural abscess. So extracranial and extratemporal, you can have neck abscesses, that is centrally abscess and benzoid abscess. Systemic, we can have systemic infection through aseptic. Yeah. So chronic otitis media, this is the persistent and recurrent infection or and inflammation of the middle ear that usually lasts more than 3 weeks. According to the country that you're in on the guidelines that you use, some ENT doctors will advocate it being greater than 2 weeks, some 3 months. So it is often associated by perforation of the tympanic membrane, eardrum, and ongoing discharge that is otorrhea, which may be continuous or intermittent. So in the diagram, you can see this is we're in the middle ear, and you can see already perforated the tympanic membrane. So the pathophysiology behind chronic otitis media, it's usually as a result of acute otitis media, and this is a continuous cycle of inflammation, ulceration, infection, and formation of granulation. Etiology of chronic otitis media, we have Pseudomonas aeruginosa and we have Staph aureus. These first two are must-knows. In addition to that, we can also have Proteus and we can also have Klebsiella. So the clinical presentation of chronic otitis media, the commonest one is this one, otorrhea, that is draining ear for long, which is often recurrent. And then in addition to that, you may have hearing loss, and this hearing loss is usually conductive hearing loss. So fever is usually absent. However, if the fever is present, it usually points to complication of intracranial or extracranial complications. So vertical may be present if it involves the rumpling. So if you have infection of the lumbi, that is lambiditis, you may present with vertigo. In addition to that, if you have false smelling, currently known as an NB, false smelling discharge usually points to cholesteatoma. So what is the investigation? The investigation, this is usually a clinical diagnosis, and if it is persistent, kindly do an high resolution CT scan of the temporal bone. Other tests that you may do, because you said it will cause hearing loss, so the patient may just actually come in with presentation of the hearing loss. You may do hearing test, that is pure tone autometry. Is this test subjective or objective? What do you think? This test is subjective. So treatment of chronic otitis media, the principle behind the treatment is number one, you give autotopical antibiotics, and the antibiotics that will usually recommend are fluoroquinolones. And then in addition to that, you can do oral toilet, that is cleaning of the ear, and you can control granulation tissue. So the role of surgery in chronic otitis media, the aims of surgery, number one is to eradicate the disease, number two is to provide a dry, safe ear and to restore the function of the ear and to manage the complications of chronic otitis. Indications for surgery include chronic perforation, that you do tympanoplasty, cholesteatoma, that you do mastoidectomy, conductive hearing loss, and otorrhea, that is more than 6 weeks despite antibiotics use, that is medical failure.